Hello friends, my name is Dr. Yash Lokhandwala. I am cardiologist from Mumbai. Today we will be discussing about ventricular arrhythmias. We will discuss this topic under the following categories, starting with the most simple, that is premature ventricular complexes, then going on to the ventricular escape rhythm, accelerated idioventricular rhythm, ventricular tachycardia, and finally the most dreaded ventricular fibrillation. So let us look at the premature ventricular complex, a very common finding, and as one grows older the incidence becomes even more. In fact, in a 24-hour Holter, about 50% of elderly people will have some premature ventricular complexes. What are the ECG features? Obviously, as the name suggests, these complexes come early in relation to the expected QRS. The QRS complex is quite wide and the ST segment and T waves are in the opposite direction of the QRS, what we call as a secondary STT changes. They are followed by a pause, and this is called the complete compensatory pause. Sometimes following the PVC there may be an inverted P wave in lead 2, which is because of retrograde conduction to the atrium. Commonly in any one ECG, PVCs are unifocal. That means they come from the same spot and therefore they have the same QRS appearance and also the constant coupling interval. We will see all these features in the following ECGs. Let us look at this 12 lead ECG. You see a normal rhythm except for the fact that there is some sinus tachycardia. There is also the appearance of very deep S waves in leads V1, V2 and V3, probably suggestive of some left ventricular enlargement. A single wide QRS complex is seen, which if you look in lead 2, the long lead 2 below, comes early, is not preceded by a P wave, is wide, and the T wave is in the opposite direction of the QRS. Also, if one measures the distance from the normal QRS before the PVC to the normal QRS after the PVC, again I repeat, from the normal QRS before the PVC to the normal QRS after the PVC, it is exactly equal to 2 normal RR intervals. So this is the meaning of a complete compensatory pause. In this single monitor strip you see 3 PVCs. All these PVCs look exactly the same. Also, the distance from the normal complex to the PVC is, which is called the coupling interval, is the same for all these 3 complexes. So this is what we say, same appearance, same coupling interval, therefore these are unifocal PVCs. And as I said before, in a majority of patients who have PVCs, the PVCs are unifocal. This is an unusual pattern. You have 6 leads, the limb leads on the left and the chest leads on the right. So if let's look at the limb leads, you see 2 abnormal QRS complexes. The first one is completely negative in lead 1 and the second one, the QRS, is completely positive in lead 1. Both of these are PVCs because they are not preceded by P waves, they come early. However, they are completely different in appearance, so these are called multifocal PVCs. Multifocal PVCs are more troublesome than unifocal PVCs and require a much more careful look at the patient and may definitely need further evaluation. When PVCs come successively, now here is a format of a 12 lead ECG, arranged leads one above the other. In different ECG machines there are different formats. So this is a 12 lead ECG simultaneously recorded, lead 1 on top down to AVF and then from V1 to V6. So after the first normal complex we see 2 PVCs occurring rapidly. They are quite close to each other, followed by a pause, and then again you find the normal rhythm. So when 2 PVCs occur together, this is known as a ventricular couplet. A couplet is a more serious form of arrhythmia than a simple isolated PVC. Sometimes you get a pattern where you have one normal complex followed by one PVC, again a normal complex, again a PVC. This is known as ventricular bigeminy. For example, if you look at this ECG, every time you see one narrow QRS complex and one PVC. Even if the lead changes to AVR, you see one narrow complex and one PVC. Lead V1, narrow complex and PVC. So this pattern keeps going on and on. This is ventricular bigeminy. Ventricular bigeminy is generally not of much concern because it rarely leads to ventricular tachycardia. This is a more easily understandable example of ventricular bigeminy because you have a long lead. The long lead 2 right at the bottom clearly shows one normal, one abnormal, one normal, one abnormal. And as expected, after every PVC there will be a pause. So you will have a longer RR interval followed by a shorter RR interval. And there is also something called a rule of bigeminy. That means whenever there is a pause, an ectopic is more likely to come. So you get a pause and then an ectopic. So short RR, pause, longer RR, normal, ectopic, normal, ectopic, example of ventricular bigeminy. Fusion complexes or capture complexes are more relevant when you have ventricular tachycardia. If you have a ventricular tachycardia, and we see examples of ventricular tachycardia, during a ventricular tachycardia, if you have a narrow complex which comes early, it's called a fusion complex, and if it is narrow, early and preceded by a P wave with a normal PR, it's called a capture complex. Actually, fusion and capture complexes help to make the diagnosis of ventricular tachycardia confirmed, but they are not very commonly seen. What is a ventricular escape rhythm? As the term implies, it's slow. It's an escape rhythm, so it's slow, and therefore it will occur when the normal rhythm doesn't work properly. So when the normal rhythm doesn't work properly, it can be because the sinus node is not working properly or the AV node is not conducting the impulses. Here is an example of complete AV block. You can see so many P waves walking through this ECG without any relation to the QRS. In short, there is no proper PR interval. So there is the atria and the ventricles are activated independently. If you look at the QRS complexes in lead V1, they are wide and they are positive. So that's what they say, like RBBB. It is not RBBB, but they look like RBBB. So they are coming from the left ventricle. And this is an example of a slow, wide QRS rhythm. We call it as a ventricular escape rhythm. And it is a life-saving rhythm in this case because there is complete AV block. So the escape rhythm is what is keeping the patient alive. As opposed to that, you can have a ventricular rhythm which is not so slow. In fact, it is at a normal rate or maybe even slightly fast, which is known as an accelerated idioventricular rhythm. This is the commonest situation where one sees this is soon after thrombolytic therapy in acute myocardial infarction. But it can also be seen in the absence of thrombolytic therapy, and it can be also seen late after myocardial infarction. If it's seen early after myocardial infarction, it's a good sign, but if it occurs late after myocardial infarction, it really doesn't help us for prognosticating. Sometimes you may see AIVR in normal people without myocardial infarction, especially younger people, athletes who have a high vagal tone. So the sinus node is slow sometimes, and you see episodes of accelerated idioventricular rhythm. The ECG features are similar to ventricular tachycardia except that the rate is slower, and typically they start with a late PVC. They also are called accelerated because the normal idioventricular rate is 20 to 40 per minute, whereas these rhythms are generally between 60 and 110 per minute. Therefore, they are called AIVR. They are usually regular and the QRS complexes are wide. This is an example of a common setting in which one gets AIVR. As you can look in leads 1, 2 and 3, there is an inferior wall myocardial infarction. In lead 3, you see a Q wave, ST elevation and inverted T wave. So this is an inferior wall myocardial infarction, and already of some duration, a few hours, because Q waves have developed. Not only that, but the ST segment has come down and the T is inverted. So possibly the inverted T wave very early in infarct is not necessarily a bad sign. It may indicate that there is a reperfusion taking place. Let's look at the long lead 2. You have 1, 2, 3, 4 normal complexes, and then you have a wide QRS rhythm setting in. Please note that the wide QRS rhythm starts with the first complex late. That means almost, actually it's after the, just after the P wave. So it's quite much after the T wave. So it's a late PVC, and it looks different from the normal as well as from the AIVR. What you are seeing from here is the AIVR. The ventricles are activated only by the ventricular focus, whereas this is what we call a fusion complex. A fusion complex. It is in between the normal and the ventricular and preceded by a P wave. So part of the ventricle activated by the normal conduction system and part of it activated by the ventricular focus. And these AIVRs, the P wave is walking into the QRS. This is called isorhythmic AV dissociation. And the P wave again walks out of the QRS, and then at a certain stage it can conduct down to the ventricle and then restore the normal rhythm. And the first P wave that is conducted as a long PR, this is because of the phenomenon of concealed conduction. We won't go into this in this lecture because it may be covered in other places, or those of you who are interested can read about concealed conduction. But this ECG is to show an example of AIVR in a setting of an acute inferior wall myocardial infarction. Now coming to the more serious arrhythmias. So far we did not talk of many serious ventricular arrhythmias, but ventricular tachycardia is a serious arrhythmia and can be life-threatening. We divide ventricular tachycardias first as non-sustained or sustained, and then whether they are monomorphic or polymorphic. A non-sustained VT is one which lasts for less than 30 seconds. That means it's self-terminating and it is not associated with hemodynamic compromise. If you have a ventricular tachycardia lasting even 15 seconds but causing syncope, you don't call it non-sustained VT. So it has to fulfill two criteria. It has to last less than 30 seconds and should be hemodynamically stable. If not, the VT is called as a sustained VT. The ECG characteristics of VT, again to repeat what we've talked about PVCs, very wide QRS, T wave in the opposite direction of the QRS, at least 3 consecutive complexes. So you have single PVC, you have couplet, and 3 or more is called VT. The rate has to be more than 100, the ventricular rate. The termination and onset are usually abrupt because most VTs are re-entrant. So they start suddenly and they stop suddenly. You might see AV dissociation in some of these ECGs, and as we discussed, we showed in the previous ECG, you might see capture beats or fusion beats. Monomorphic ventricular tachycardia, the QRS complexes all look the same. Usually the rates are more than 140, but they can be almost up to 250 or rarely even up to 300 beats a minute. Here is a 12 lead ECG, again in a different format, 3 leads in each column, and you see 3 ventricular complexes, then 2 normal complexes, again 3, then 2 normal. So this is repeated non-sustained monomorphic VT, or this may not be repeated, but if this is simultaneous recording, this may be just one episode of non-sustained monomorphic VT seen in the 12 leads. So this is monomorphic non-sustained VT. On the other hand, here you clearly see a VT which terminates, restarts, and this time it is a little longer. It has not terminated till the end of the ECG. So this is non-sustained repetitive monomorphic VT. Is repeated, it's non-sustained, and the QRS complexes in any one lead during the VT look the same. So if you look at lead 2 or if you look at lead V2, the QRS complexes look the same. And please note, here the VT starts with the early PVC. It starts soon after the T wave. When I showed you the example of AIVR, I showed you how it started late, whereas VTs generally will start with the early PVC. Look at long lead 2 here. One normal complex, a triplet or non-sustained VT, normal complex, 5 beats of VT, the rate is almost about 170, 3 normal complexes, again non-sustained VT. So non-sustained monomorphic VT repetitive. As opposed to that, this entire tracing is a VT. You see a wide QRS rhythm, the rate is about 175 to 180 per minute. The QRS is not only a wide, but they are notched. The T wave is in the opposite direction of the QRS. You cannot make out any P waves. There is a negative concordance from V1 to V6. The QRS complexes are all negative. When you have negative concordance V1 to V6, it has to be VT, and there is a left axis deviation during VT, and the QRS complexes are negative in 2,3 AVF. So this is an example of a sustained monomorphic ventricular tachycardia. The commonest setting of a sustained monomorphic VT is in a patient with an old myocardial infarction, and we then call this VT as a scar, myocardial infarction scar VT. But you can also see sustained monomorphic VT in patients with any type of cardiomyopathy, and rarely even in patients with normal hearts, what is called idiopathic VT. This is a very rare type of VT. If you look at the long lead 2, you find that all the QRS complex in the initial part are wide. However, you see 2 alternating patterns, a negative QRS and a biphasic QRS, negative and a biphasic QRS in perfect alternation. So this appearance is called as a bidirectional VT, a very rare form, previously seen when digitalis was used much more commonly. It was a hallmark of digitalis toxicity, very serious arrhythmia, but in this particular patient it was because of aconite toxicity acquired from homeopathic medication. So having looked at monomorphic VT, the rare bidirectional VT, we now come to polymorphic VT. Polymorphic VT, the commonest setting is an acute coronary syndrome, acute ischemia, but you can also see it when the milieu interior is disturbed, especially severe hypokalemia. And finally, you can see it in some patients who have a congenital channelopathy, what you call a long QT syndrome, in which case it has a characteristic appearance which is called as torsade de point, twisting of the points. So in general, the ECG features of polymorphic VT are that there are wide QRS complexes, but they keep changing beat to beat, and you actually have at least 3 different morphologies, no one constant morphologies, and they are typically very rapid, more than 200 beats per minute, irregular and bizarre looking. So let's see this example of polymorphic VT. This is actually recorded during a stress test. So you can see the limb leads, and in the limb leads actually you are already seeing a lot of ST depression and also some ST elevation. So there is severe ischemia, and soon the patient gets a PVC on the T wave, This is what we call R on T. The PVC occurs on the T wave, QRS occurs on the T wave, R on T phenomenon, which leads to a polymorphic ventricular tachycardia, or degenerating intermittently into ventricular fibrillation. So this is polymorphic VT. And finally, ventricular fibrillation. You will rarely get an ECG of ventricular fibrillation because the patient will be in cardiac arrest and someone will be giving massage or other forms of resuscitation or delivering a DC shock. So it's a chaotic ECG. There are no definite complexes, neither QRS nor T nor P, and the rates are up to 500 per minute if at all you measure the rates of whatever undulations you see on the ECG. This is a rare ECG, a 12 lead ECG of ventricular fibrillation. Actually, you should never have a 12 lead ECG of ventricular fibrillation, because while you are recording the ECG, you should, instead of doing that, you should be massaging the patient or resuscitating. But we have this example of a 12 lead ECG showing undulating complexes, very rapid, no definite pattern. This is one form of cardiac arrest, ventricular fibrillation. If you see ventricular fibrillation or polymorphic VT, you must always run for the defibrillator, because resuscitation here doesn't start with ABC but starts with the letter D for defibrillation. And this is an example of polymorphic VT, patient in collapse, defibrillator activated, pads put on the chest and shock delivered, patient life saved and restores to sinus rhythm. Okay, so we come to the end of our lecture on ventricular arrhythmias. Thank you for a patient listening.